What does it mean to culturally adapt cognitive behavioral therapy? Does it include translation of language and concepts of CBT and illness? If we do make adjustments to therapy, which ones tend to hold greater cultural influence? In order to adapt CBT treatment so that clients can engage with us, and as mental health professionals delivering such treatment, we must understand how clients think about why they are struggling with mental health issues. Listen to my much-needed conversation with Dr. Farooq Naeem, a pioneer in cultural adaptation of cognitive behavioral therapy. Welcome to People of Color in Psychology, the show that explores mental health topics specific to culture, diversity, and communities of color. I am your host, Jack Zen. Today, we have Dr. Farooq Naeem. He is the professor of psychiatry at University of Toronto and psychiatrist at the Center for Addiction and Mental Health. As a psychiatrist, cognitive behavior therapist, clinician scientist, a leader of global mental health for his pioneering work on cultural adaptation of cognitive behavioral therapy, and the founder of Pakistan Association of Cognitive Therapists, Dr. Naeem's belief is that evidence-based psychosocial interventions are a human right, not a privilege. Dr. Naeem has a tremendous body of work in research and implementation. He currently leads a special interest group for the World Psychiatric Association on implementation of mental health apps in low and middle income countries. Additionally, he has adapted CBT for use in South Asia, North Africa, Middle East, Kenya, and China. With over 20 randomized controlled clinical trials under his belt and over 200 published papers, more recently, Dr. Naeem has taken these experiences by adapting CBT treatment for South Asian Canadian clients through a multi-phase mixed methods approach to align the needs to this specific population and region. This year, in 2023, Dr. Naeem published an invited paper titled Culturally Adapted CBT, the Evolution of Psychotherapy Adaptation Frameworks and Evidence. As a British-Canadian South Asian psychiatrist, Dr. Naeem will be discussing with us the importance of why CBT treatment needs to be adapted. Dr. Naeem, it is such an honor to speak with you today. Thank you for joining me.
Thank you for inviting me and giving me this opportunity to talk about something that's very close to my heart. It's a privilege.
When you mentioned that this work is very close to your heart, I mean, you've published over 200, papers on this subject matter. For listeners who are, who read about your work, who are listening to this podcast, something I think a lot of people would like to know is your origin story of how you got into this work. Is that something you
Absolutely,
would be? Yeah.
Yes, no, I can. You see, it's very kind of not a very complicated story. So I was working as a senior lecturer in Southampton, and that was the time. So I've been trained in CBT, by the way, for more years than many people in psychology and psychotherapy, etc. I know. So residents. During my residency 4 years, and then senior residency 3 years, and my PhD another 3 years. So I had a lot of training in CBT, and then I had an MSc in research methodology. So because of that, I was working with David Kingdon, who's a pioneer in CBT psychosis. So I was trained in CBT psychosis, and we were looking at the data from 2 or 3 major trials that were conducted in the UK on CBT psychosis. One thing I noticed was that even though the trials recruited from London and from Birmingham and Manchester, which are very non-white sort of cities, but it was shocking that 90% of the patients who were recruited in these trials were white.
Oh.
So I said, what's going on here? So I just, it's like one of those kind of moments. So I said to David, what's going on here? Because these are predominantly non-white cities. I mean, you can Google Birmingham and Manchester and London, UK, and see how many are. You just go and you see. So I thought, what's going on here? Why not? Why? And then it turns out that partially it is a kind of recruitment bias, but also people from non-white kind of background do not uh, seem to be interested in psychotherapy, and those who are interested, they drop out very soon.
Mm-hmm.
So that was the kind of first time. That was the first. That's how it started. And then I said to Dave, so, okay, we should do something. So then I started. Then I thought I'll do something. So I thought, okay. Then I, thought about this project to adapt CBT, initially for psychosis, and then I actually moved to depression. I did psychosis a few years later, but I thought if I do for depression and anxiety, first, it will be an easy to develop model, and second, more people might benefit because depression and anxiety are more common. So that was really the main kind of observation that led to my work, and then actually I started looking at the research. This is like we're talking about 2005. That's when I started my work, more kind of in a serious kind of sense in 2009 or 10 when I completed my PhD and published my model. I became interested in what's going on, and I looked at the literature. There was actually mostly the literature from North America, and there were a few publications, but they all were personal experience rather than any kind of scientific work, to be honest with you.
So you mentioned noticing the difference in the recruitment. What do you suppose enabled you to recognize that difference as something important?
Yep. You see, first of all, because of my own multicultural background, I recognize the differences in cultural norms and values among even the different cultural backgrounds that I come from. But also when I was in training in UK and receiving psychotherapy, I realized that unlike medication, for which you don't really need to think that much about culture, when you think about psychotherapy, you cannot ignore the cultural values. For example, in the West, when we try to help someone through psychotherapy, the purpose is to help that person to live individually, because the Western cultures are very individual focused. On the other hand, when we are helping someone from an Asian kind of background or South Asian background, the focus should be how they adjust to their family, to their wider community. So you see, even the aim of the psychotherapy becomes different when we compare West with the East. Similarly, there are many other kind of reasons, really. For example, many people who are from non-Western background, when they go into therapy, they find it difficult to connect with the therapist. There's so much data that shows that people from a Western kind of background, they find it difficult to understand where these people are coming from. For example, their family or communal living, for example, their interdependence on each other. Even the communication patterns are different. For example, in the West, we have this collaborative model in which therapist and the patient are equal. In the East, we don't have that because Eastern cultures are still, even now, very patriarchal. So that means therapist is seen in very high esteem. So if a therapist tries to treat the patient equally, the patient wouldn't be very comfortable.
Yeah, you've definitely written about that, as well as how people may adapt certain CBT stance, such as, something more directive problem-solving approach for potentially the
That's correct.
Asian and South Asian clients. Now, the work that you're involved with too is the adaptation of CBT for South Asian clients in Canada. I'm wondering if you've noticed acculturation of the South Asian clients playing a role, because
Okay, yes. No,
yeah,
I got it. Yeah.
okay.
Yes, you're absolutely right. Acculturation, when you adapt therapy for clients living in South Asia or Asia, you focus is on different things compared with when somebody living in the West, because acculturation plays a huge role. And therefore, when we train people in culturally sensitive CBT, the first and the most important thing is to assess their level of acculturation,
Hmm.
right? Because if you don't do that, if you just assume that everyone is still Asian in their values or they're very Western in their values, it's surprising, and I still don't know how does it work. But I have seen second, third generations, both in the UK and Canada, who still are very Asian.
Hmm.
And then you see first generation who are very westernized. So so that's the first lesson, never ever assume about the level of acculturation of people living in the West, because there's so much variation. Acculturation is really a very interesting thing, because it depends on a variety of factors. For example, your level of education, what are you doing? How much time do you spend with the general community? And I think it's more to do with your level of acceptance in the host society, because I think
Hmm.
acculturation, like I have seen that, when people feel they're being forced to acculturate, it backfires.
Oh, I love that message you're highlighting here. There's a
Yeah, that's a very
distinction.
important thing. Yes.
Yeah, yeah. Distinction between natural acculturation versus a forced. Yeah.
Absolutely, absolutely. Because in some countries in the West, especially in Western Europe, I see a kind of people receiving this message. You need to adapt to our cultural values and to our culture. I think Canada is a kind of bit lucky because I don't see that much of pressure here, and then I suppose that's because of the demographics, because it's very small kind of population. But it's then again that pressure is not uniform. That's what I'm
Mm,
trying to say. In
mm,
different
mm.
countries, you'll see different kind of emphasis, but it's a huge factor. If you try to, it's just like really, if you think about forcing your religion on someone, because if you think about it, your belief system is just like your religion. It's you are made up of your belief
Mhm.
system, and if therefore somebody forces you to change your belief system, you're not going to change that. You only change your belief system when it suits you,
Yeah, yeah,
right?
yeah, and I think this is something I also wanna bring in too with this conversation. You've also written about the changing the idea of the biopsychosocial model to biopsychosocial spiritual model, which,
That's correct.
which
That's
we're on
correct.
a conversation of,
Yeah.
spirituality and religion.
Yeah.
Can you give me some examples how that plays out, say, in your work? And
Yes.
yeah.
Sure. So you see, the traditional kind of model of mental illness is biopsychosocial model. That's the model in which I was trained. And I remember when I was trained like 20 years ago, it was actually a sin to talk about spiritual or religion, as spirituality or religion in psychiatry. So luckily, that's the one good thing, first of all, that we talk about these things now without offending many people. But yeah, so for example, we have someone who has a religious background, and therefore they might believe that the illness, the depression, is because of sins they have committed. Okay, they might feel that they are depressed because they were being disrespectful to their mother or father.
Mhm.
So you see, there's so many different kind of non-medical or psychological or social explanations of mental illness in many other cultures. And if we don't consider those in therapy, we're not going to engage people. If you don't talk to someone who has these concerns, many were of the Abrahamic religions, for example, Christianity, Islam, Judaism, all have a concept that the person who's not a good follower will be unhappy, which is misinterpreted as, depression is caused by not being a good follower. So as a therapist, if you don't know this subtlety, and don't try to teach people, educate people on this misinterpretation, you're not going to be able to help them.
You're really highlighting here, because when I'm thinking about the CBT model, and for instance, we look at people's automatic negative thoughts and we drill it down to ultimately what's your negative core belief. And then we start to examine, well, how did this negative core belief develop? How was
Yeah,
it reinforced over time? And
absolutely.
yeah,
Yeah, because you see, the thing is, religion and culture always have gone hand in hand. The thing is really the modern Western civilization, the last 100 years or so, is a kind of a unique example in our history, when religion and the state have become separate. That's a very important development in the history of mankind. It doesn't mean everybody has that kind of way of looking at the world. People's worldview is influenced by religion. When I was younger, and I started traveling, I used to travel a lot, and I was very much interested in architecture. And the best preserved buildings in the world are the religious places. I used to go and see all those kind of buildings. Well, one thing I realized was the different kind of images of Jesus in different cultures. So I have seen a black Jesus, I've seen a
oh,
Latino looking Jesus, I've seen an Asian looking Jesus, and I've seen a very blonde and blue eyed Jesus. So you see, the interaction between culture and religion is a very important consideration that we should never ignore. And that means your belief system in many cultures is formed on your religious beliefs. So your belief system is not really just, like what you watch on the TV or school. You learn a lot from your parents and what they believe in. For example, if you fall down, or if you're hurt, in many culture, the explanation still, even in this day and age, even among the educated ones, is an evil eye. So evil eye, the concept of evil eye is, someone gave you bad look, and that's why you are hurt.
yeah, okay.
Right. So that kind of explanation for the natural events is still prevalent in many cultures. So what do? How do you deal with that when the cause and effect is not just pure biological or psychological or social, but there's a
Spiritual, yeah, there's a
explanation?
spiritual, yeah.
Explanation, right?
Mm,
Similarly, in many Muslim countries, there's still a concept of jinn, the unseen creatures which can cause mental illness.
mm,
So, so it's very important to take into consideration these things rather than just saying, okay, for that, for your spiritual kind of explanation, you go and see a faith healer, and for the rest, you talk to me.
yeah. Wow. As you're talking about that, there is a degree of leaning into the spirituality rather than saying, hey, I mean, because we're actually creating more barriers if we tell clients, please just go to this center, this synagogue, this spiritual location, and you're not interacting, and there isn't like a willingness to even hear from the
Yes,
client. Wait, share with
exactly.
me, say some of the pillars of Islam, like share with me some of those ideas and help me understand. Yeah, have being able to be comfortable in having those conversations.
Yeah. So I think it's not really, that you need to be a religious or spiritual scholar as a therapist, but you just need to be aware of these factors, So you need to be able to talk to them about these things. If you find something that is a misconception or misunderstanding, you can address those, or you can refer sometimes even to faith healer, and say, okay, this is an issue that I don't know what's going on here. But the whole idea, the emphasis is really about willingness to consider those spiritual and religious factors. And it's not just really those religious and cultural factors. There are many non-religious and cultural factors too. For example, many people in East, even in this day and age, and they bring those beliefs here to the West as well. So they do believe, for example, that the mental illness or physical illness can be caused by increased heat in the liver, which is a Greek
Yep.
medical concept, very common in Asian countries, or it can be because of the increased heat. That's a Chinese medicine concept. Apologies. And then the increase in bile or blood, which is a Greek concept. So these concepts are very prevalent. Even the Indian concept in South Asia and Middle East is very popular, that mental illness can be caused by excessive masturbation. So you see, these beliefs are there. We can't ignore people's explanations, because if you ignore what a patient believes, this is his illness is being caused by this, you disengage. You're not serving them.
Because we're not understanding their point of view. And I think something that I'm curious about, because you developed the Southampton model of cultural adaptation, and I guess something for our listeners. Can you briefly share with us that model?
So the Southampton Adaptation Framework was the first cultural adaptation framework that's based in research, because when I started working, it's like 2009 when I published that. And that was a time when most models of adaptation were just described on the basis of therapist experience. So I took a different approach. I thought, rather than just describing my experience, and I would rather talk to patients, their families, to mental health practitioners who are working with this group, community elders, or who are the experts in these cultures. So I engaged all the stakeholders, and that's how we developed the model. The model has three main kind of areas, and the first one is awareness of cultural and religious issues. The second one is related to the assessment. So, for example, you, as I mentioned, acculturation is a big part of the assessment. And the third part of the model is adjustments in therapy techniques. Each of these areas then has 8 sub areas. So the total kind of 24 principles that you need to follow in order to culturally adapt CBT.
Thank you very much for giving us an overview of the Southampton model of cultural adaptation. Can you tell me what might stand out, or one of the differentiating factors of this particular model versus the others?
I think the big kind of difference that in Southampton adaptation framework, one is that I said, please consider religion and culture of the client. That was the big kind of thing. Second was in terms of communication. And believe me, I was under heavy criticism when I used to say to people, because most therapists are trained in the Western model, So when I used to say, you need to start with a teacher and student kind of relationship with the patients, if their acculturation is very low, rather than being equal, so that clients are not uncomfortable. Right. Similarly, the family, there was a huge kind of issue again, and a lot of criticism I received, because people are used to not working with the families. There are issues around consent and all those kind of things. The problem is, if you do not engage the families, for many cultures, Asian, South Asian, even Latino, and even some African culture, if you don't engage the family, the clients will not come back. And then obviously, as I said, the differences in terms of adjustment. And well, finally, the adjustments in therapy, I think the main thing I'm saying is that obviously, it's not my personal opinion. That's all based in all these last few years of research. For behavioral techniques, you don't need to do much, like behavioral activation, problem solving, all these things, and behavioral experiments. But for the cognitive technique, you need to be more sort of careful, and that's where your minor adjustments in therapy take place. But overall, really, the big part of cultural adaptation is not so much techniques, but engagement.
Engagement. Can
So
you
yeah,
tell
so
me
engaging
how? Yeah.
people,
Okay.
engaging patients. That's the big part of in cultural adaptation.
Got it. Got it. Okay. Throughout the years of you doing this work, what have you learned, or did anything surprise you over time?
I learn something new every time I study or reflect on culture and psychotherapy, and I think there are many things that I admired, to be honest with you, and it's not so much about the psychotherapy, but generally the resilience people have in many non-Western cultures in terms of their how they cope with mental health problems, and generally with the physical health problem, generally with the adversity. So that is the most kind of heartwarming for me to see how resilient people are outside of the West, the way they kind of cope. Also, I realized, when you think about the number of therapists, a number of psychiatrists in China, in India, in Pakistan, and when you compare that with, say, for example, Canada, where we have 6,000 psychiatrists for 40 million people,
Only
and
6,000 there?
we have 6,000 for 40
Oh,
million, yes,
wow.
and then you have 6,000 for uh, 200 million, sorry, 600 for uh, 250 million in Pakistan, and the population of India, that's 10 times larger than Pakistan. They have 6,000 psychiatrists. So who is providing mental health care in these countries? And I think my impression is that they get first of all, they're resilient, but also they get help from non-medical or non-psychiatric or psychological sort of therapists. And that was an eye-opening thing for me when I started thinking about other sources of support. Many people from Asian background, when they are even in Canada or in the UK, or I'm sure is the same in the US, they take their own therapists as well. They have their herbal and healers, right? They have their spiritual healers. They have their traditional kind of healers. So they take the therapist with them, when they go to West.
Mm. Now, one question I ask all my guest speakers is, as a person of color, can you share with me some of the challenges you faced that you would be willing to share and that you overcame those challenges?
Absolutely, yeah. So you see, the Western countries are absolutely, there's equality in the health system when you're a junior sort of psychiatrist. The competition starts when you move up the ladder. So, if you are just a quiet kind of psychiatrist, or therapist, you just go 9 to 5, do your job. You definitely enjoy the equity and equality. The issue starts when you are competing for the higher positions.
Yeah.
That's all I can say. So, that's where the battle begins. So, if you're not competing for the higher positions, the environment is very equity and equality, and all those things are there.
Yeah, but when competition for advancement, resources,
Absolutely.
recognition,
Yeah.
that's usually when, and that's very consistent with a lot of the research studies.
Yeah.
Yeah. Well, Dr. Naeem, I mean, it's been great seeing, the work that you produced. Also, I think 2 months ago, you and your team posted a CaCBT for South Asian training video online. I had a
That's
chance
right.
to look through that. It's amazing. Love it.
Thank you.
And so, lastly, do you have any final thoughts for our listeners?
Absolutely. So first of all, the videos that we have produced are free. They're more like introductory training to give people an idea of the subtleties in this area. And I think the important thing is, doesn't matter how much I or other colleagues who are working in this area, whatever we do, implementation of psychotherapy is something that's very serious kind of concern of mine. That will not happen until unless we engage people from Asian and non kind of, Asians and Black and Caribbean and Latin and all the kind of communities who currently don't get psychotherapy. We need to engage other communities, number one. And it is going to be a political struggle. Believe me, I have noticed how psychotherapy became available in the UK, for example. It wasn't really because of the goodness of hearts of the politician. It was because the politicians felt pressurized by the general public that we need more CBT. And that's how the funders actually start putting more money for CBT in England. And I think the same thing happened in Canada, where I'm sure they completed a pilot of publicly funded CBT. So the point is, in order for research to be implemented in this area, we need a political pressure as well.
Mm-hmm. And lastly, how do we support you? Your mission?
Well, I think, just spreading the word really that you're doing, and it's very kind of you. That's all we need to do to make people aware that, look, we need more psychotherapy for who are not from the mainstream disadvantaged communities, and they also benefit from psychotherapy. We need to dispel the myths like people from non-white kind of background are not psychological minded. It's just the biggest kind of nonsense I've ever heard in my life. And educate people, not just educate the ethnic minorities, but also the funders that, look, these people will benefit from psychotherapy. And it's very important because if you think about it, psychotherapy benefits people. The cost is recovered of psychotherapy. It adds to the prosperity of a nation by making people mentally healthier, So I think it's a win-win situation for everyone.
Yeah. Well, Dr. Naeem, thank you very much for being on our podcast. It's been a pleasure to speak with you today.
Thank you so much. Pleasure's mine.
I hope you liked this episode. Please subscribe and share. We love to hear from you, so send me a message on LinkedIn or email. The People of Color in Psychology is brought to you by the Multicultural Counseling Institute, and I'm your host, Jack Tsen.